Just last week, a couple from Iran brought their 13-year-old child, we'll call him Amir, to Mount Sinai Hospital here in New York, seeking treatment for two mysterious but minor abnormalities: hypospadias with bleeding and breast development. The physician determined that Amir has what doctors call a 46XX karyotype, both a uterus and ovaries, and severe adrenal hyperplasia, which caused him to develop typically male characteristics despite being genetically female. So while Amir looks like a boy, he is biologically a girl. The bleeding he was experiencing, it was actually menstruation. Amir is what we today call an intersex person. He was born with anatomy that doesn't neatly fit the typical definitions of male or female. It's estimated that intersex conditions affect as many as 2% of live births. That is 1 in every 50 babies. In the 1960s, in the United States and Europe, it became popular for babies displaying intersex characteristics to be assigned a gender by their physician and surgically altered to better fit that assignment. The argument was that being intersex constituted a social emergency that could be fixed through surgery to make intersex children not only appear more normal, but also help them develop gender behavior consistent with their assigned sex. The medical community at that time believed that gender was socially constructed rather than biologically determined. However, it is now well documented that these surgeries meant to prove that a child's gender could be determined with surgical intervention failed at too high a rate to be continued. Loss of fertility and genital sensitivity, complications with urinary function, and high rates of depression and suicide make surgical gender assignment of children today extremely rare. Yet, Amir's parents are asking his physician to order just such surgery. They want the immediate removal of Amir's uterus and ovaries, as well as hypospadia surgery to correct the physical appearance of his penis, a double mastectomy to remove his breasts, and hormone therapy so he could go through typical male puberty. And Amir's parents want all of this done without involving Amir in the decision-making and without informing him of his condition or his capacity for female reproduction. Amir's is a complicated case. There are the obvious questions. What should his physician do? When, if ever, is it morally acceptable to surgically alter a healthy child born with both male and female sex organs? But there are also more subtle questions. How far should physicians go to respect the cultural differences of their patients? Should Amir's physician comply with the father's wishes, even if doing so could do irreversible harm to Amir? Certainly, physicians should be respectful of cultural differences, especially when the parents are in the best position to appreciate what a treatment will mean within their own culture. Amir's parents fear that if he does not receive surgeries to make his appearance more normal, he faces the very real possibility of being murdered by religious zealots. The parents also know their child best. Amir's parents can reassure us that he has exhibited typical male behavior to this point. Thus, he would be unlikely to transition well to life as a female. Yet, if we comply with the parents' wishes and order these surgeries for Amir without his consent, we risk doing irreversible harm. He will never be able to have children, thus losing the deep connections he could experience through creating his own family. And there is a high risk that he will experience reduced sexual pleasure. Importantly, more and more long-term research is showing the negative effects non-consensual gender assignment has on patients' psychological health. In the United States today, treatment for intersex people is very consciously moving toward counseling acceptance of differences rather than surgically forcing conformity. So here's my considered opinion. The physician should order the double mastectomy. It's not irreparable. We have Amir's consent. It respects the parents' wishes for Amir to live as a normal young man, and it is considerate of the importance of Amir continuing to enjoy the connections and relationships he has grown to depend on. However, the physician should not order the other surgeries. Instead, we should offer Amir hormone therapy to delay his puberty. With Kant, I consider Amir to be a rational human being who deserves to be treated as an end in himself. As such, his consent should not be disregarded, even though in his culture he is still a child. If Amir goes through surgery, it is not the case that afterward he will live completely cured and free of problems. Even if we do the surgeries the parents want, without Amir's consent, he will need to take part in lifelong hormone therapy. If he does not understand his own condition, he cannot be expected to make informed decisions later about his own care. If Amir's case presented a medical emergency, it would be inappropriate to delay surgery. However, a social emergency is not a medical emergency. And delaying surgery until Amir is able to make his own decisions is appropriate because the hormone therapy will effectively hide the issue, thus keeping intact his social connections and keeping him safe from religious zealots. My belief is that it is more important to do this right than to do it quickly, and doing it right requires Amir's full informed consent.